Thank you very much for your kind introductions, and thank you for having me here too. So my topic today is assessments of tremor in clinical practice. My name is Pattamon Panyakaew from Bangkok, Thailand. So let's just start with these two patients and see who has tremor. So the patients here, the ladies, has like a system, rhythmic oscillatory movement of the hands, which is more consistent with tremor. While the patients here, the gentleman, he has the movement that look like tremor, but in fact, this is irregular and jerky, which is more consistent with cortical myoclonus. The first step in approaching tremor is identifications of rarely tremulous movement and exclusions of tremor mimics. This table shows the clinical clues for differentiations between tremor and cortical myoclonus. As I showed you earlier, tremor is a rhythmic oscillatory movement, so it can be regular, but sometimes it can be irregular in some tremor syndrome or the tremor syndrome with bigger amplitudes. While the cortical myoclonus is a shock-like and jerky movement, with usually irregular, but it can be rhythmic with repetitive myoclonus. So you can see here that tremor and myoclonus has a clinical overlaps. Let me start with the case demonstration 1. So this is a young female who presented with 3-month history of action tremor of bilateral hands. She has the underlying of anxiety and depression and has been taking mirtazapine for years. She denied family history of tremor and unknown alcoholic responsiveness. You can see here that she has like action tremor of bilateral hands, but more predominantly at the fingers. And when she does the finger to nose test, you can see that the fingers has a simple kinetic movement, but is this the same while approaching the target? What is the most likely diagnosis? I think everyone may think in your mind, and let's listen to this classification first. Clearly, tremor is defined along two axes, the clinical features in axis 1 and etiology in axis 2. Determinations of tremor syndrome is based on the history taking and careful examinations. Tremor examinations are consisting of tremor assessment in the different conditions, including at rest, postural, kinetic, and task-specific. And you have to look for the specific sign for functional tremor in cases you suspected of, including distractibilities and entrainment. You have to also look at the characteristic amplitude, frequency, and distribution of tremor. And more importantly, you have to look at the associated neurological signs, including dystonia, Parkinsonism, cerebellar signs, and neuropathies. Activation of tremor should be defined for tremor assessment. We have to see whether the patient has rest or action tremor. And in action tremor, it can be classified into kinetic and postural. For kinetic tremor, it can be more like subtype into the simple kinetic tremor, intentional tremor when approaching the target, task-specific kinetic tremor. And for postural, you have to look at the position independent. It means that the postural tremor can occur in either positions or position dependent. So it means that the postural tremor can be occur only in one position. The distribution of tremor is also important to determine tremor syndrome. This table shows various distributions of tremor of different tremor types. The dark blue color here indicates the most frequent area of involvement in each tremor syndrome. You can see that approaching upper limb tremor here is the most difficult since there are many tremor syndromes that involve upper limb either unilateral or bilaterally. The frequency of pathologic tremors can be at 4 to 8 Hz, while the physiologic tremor is about 8 to 12 Hz. However, there could be an overlap between the pathologic and physiologic tremor and difficult to see by eyeballs. The tremor syndrome that has a frequency higher than 12 or lower frequencies than 4 Hz could be easier to evaluate by the clinical evaluations. Besides the characteristic of tremor, we have to look for the prominent additional signs, such as dystonic posture, Parkinsonism, cerebellar signs, and brain stem signs. Pattern recognitions here, for this size, you have to differentiate whether the patients have combined or isolated tremor syndrome. And pattern recognitions will guide for the diagnosis of certain tremor syndrome and guide for the investigations in the axis 2. In summary, there are 2 steps of approaching to tremor. The first step is to exclude the tremor mimics. The second step is to determine whether the patient has isolated or combined tremor based on the focused neurological examinations. Diagnosis of tremor syndrome can be changed with time if additional signs develop. Tremor syndrome can be classified into rest or action tremor, as I mentioned earlier. The tremor basically at rest can be in Parkinson's disease, Parkinsonism, essential tremor with rest tremor, or dystonic tremor. While the patients that predominantly act action, either postural or kinetic, could be enhanced physiologic tremor, ET, dystonic tremor, drug-induced tremor, or neuropathic tremor. In this case, the ladies has mainly action tremor, so the patients could be enhanced physiologic tremor or ET. And how to differentiate between essential tremor and enhanced physiologic tremor? Tremor in both syndrome usually present during actions, but in essential tremor, it usually presents at the kinetic with intentional component rather than postural. While the enhanced physiologic tremor, it can be both like either postural or kinetic, but not intentional component. The distribution would be both at the bilateral hands, but could be more distal in enhanced physiologic tremor. The frequency can be overlap between these two syndromes, especially in the young adult. But we can use the different pathophysiologies of essential tremor and enhanced physiologic tremor to differentiate between these two syndromes. We know that enhanced physiologic tremor come from autoactivities of the peripheral components. So when we put the weight on, that is the decrease in terms of the frequency more than 1 Hertz. The agitation lab is not indicated if clinical assessment is clear. Since this lady, she has short durations of the tremor, predominantly at the postural or kinetic. We have to look at the secondary cause, and we have to look over the blood tests such as thyroid function test, metabolic or toxic. If the patient has a young onset as well, but has both rest and postural with subtodystonia and Parkinsonism, maybe we have to test for serum ceruloplasmin to exclude Wilson disease. For structural imaging, maybe we can do that in the case of focal tremor that restrict only in focal or just one side of the body. The functional imaging can be done in patients who had suspect of drug-induced tremor or essential tremor versus PD because we want to know whether the patients have dopaminergic denervations or not. Electrophysiological study, including the accelerometers and multi-channel surface EMG, can be done in the case of complex movement that maybe we differentiate between tremor and tremor mix, also document for the sign of functional tremor. Moving back to this case, and you can see here that we have done the thyroid function test, and the result turned out to be very high, 333 and low TSH. So the final diagnosis is thyroid toxicosis induced enhanced physiologic tremor. We might have to think about drug-induced tremor in this case because she has been taking antidepressant. But the SSRI, especially fluoxetine, is the most common cause of drug-induced tremor, especially in the postural tremor. But when you look at the data for mirtazapine, this is less likely to cause tremor and other movement disorder. The most important key for the diagnosed drug-induced tremor is the temporal relationship between the tremor and offending drug. And you can see here that she has been taking it for years, but the tremor just started within 3 months. Let me recap the difference characteristic between enhanced physiologic tremor and essential tremor. You can see here that this lady has more predominantly tremor at the fingers like this, and is more prominent with the finger or the kinetic movement with the simple kinetic, not intentional component. While in essential tremor, you can see here that the movement is like flexion extension of the wrist. And also with the kinetic movement like this, you can see that she has not only simple kinetic but also intentional tremor. So this is consistent with essential tremor. Let me move to case 2. So this is a 40-year-old male who presented with 4-year history of right hand tremor after waking out. And the tremor recently increased and he has alcoholic responsive. He also has a family history. His mother has the same history for many years. And you can see here that he also has fine amplitude and high frequency tremor at bilateral hands during action. But once we asked him to do the finger to nose test, you can see that not only simple kinetic but intentional component was present as well. And when we asked him to do the spiral lighting, you can see there's a tremor in both hands. So this is consistent with essential tremor. So this is the definition of essential tremor that include the isolated tremor syndrome of bilateral upper limb tremor, at least 3 years durations, with or without tremor in other locations and absent of other neurological signs. Essential tremor plus is look like essential tremor, but these patients can have additional neurological signs of uncertain significance, such as impaired tandem walk, questionable dystonia, and memory impairment. And essential tremor with rest syndrome can be categorized into this one ET plus. And I have to let you know that isolated focal tremor, such as isolated head or voice tremor, is not in the category of ET anymore. ET is a syndrome, not etiology. So it means that ET can have multiple etiologies, either idiopathic, familial, genetic diseases such as SCARS12, DYT24, or other neurodegenerative disorders such as Wilson disease. ET can be evoluted to other syndromes, and you can see here that ET and ET plus has a clinical overlap due to the similar pathologies and the responsiveness to DBS. And ET plus is more common than essential tremor, and ET plus has older onset, longer durations, having rest tremor and non-motor symptoms that indicate later stage of essential tremor. So this is the revised definitions of essential tremor that included upper limb action tremor that has a predominantly kinetic component and usually bilateral but may start in one arm and can occasionally remain unilateral. Rest tremor can be present, but it usually less severe than action and should not be anatomically separate from the action component. Let me show here, this is two patients. This first patient has ET plus. You can see here that she has a rest tremor here at the left hands. And once we ask her to hold the hands up, you can see here that she has tremor right away bilaterally, but more on the left hand. So this is no pause, so this is a postural tremor. And she also has tremor in all positions, with this position, and wing positions. And she also has a kinetic tremor with intentional component. And sometimes she has head tremor as well. So this is ET plus because he has rest tremor in the same limb as the action with bilateral, even this is asymmetry, and has subtle dystonic posture of the head. While this lady, you can see here that she has rest tremor of the fingers bilaterally. And she also has the head posture, abnormal head postures, right? And has a head tremor. And you can see when we ask her to hold the hands up, you can see a little bit dystonic posture. And she doesn't have tremor in these positions, but once she has gone to this position, she has a tremor only on one other right hand, and with this position as well. So I think this one, everyone agree that the patient has dystonic tremor since the patient has rest tremor, the head and the action tremor that occur unilaterally and position specific, and also clear dystonic posture of the head. So the patient with dystonic tremor is the combined tremor syndrome with dystonia. Some isolated tremor like focal tremor or isolated segmental action tremor is a controversy issue. It can be dystonic tremor or maybe part of the essential tremor. So we don't know about it right now, but we have the separate entity. This table shows the difference characteristic between PD tremor, dystonic tremor, and essential tremor. You can see here that tremor in ET is more prominent during actions, while in Parkinson's disease, the tremor is most predominantly at rest. In dystonic tremor, it can be both at rest and positions, and it can be position specific or task specific. The tremor in dystonia is jerky and irregular, which is different from essential tremor and PD tremor. And as I mentioned earlier, I would like to emphasize that isolated head tremor, voice or jaw tremor could be in the category of dystonic tremor. And we have to look at the additional signs such as Parkinsonism and non-motor symptoms that point to the diagnosis of Parkinson's disease and dystonia in the category of dystonic tremor. But the problem is the subtle dystonia. Someone you can say that, oh, well, I think this is very frank dystonia, but somebody said that, oh, this is very subtle, so this is very difficult for dystonic tremor. So this is the difference between isolated head tremor here. So this lady, she has isolated head tremor, but actually you can see that she has a little bit abnormal posture, and the tremor has a little jerky and irregulars. And when we ask her to hold the hands up, you can see here that she doesn't have hand tremor. So she has isolated tremor with a little bit dystonic posture. So could be in the category of dystonic tremor. While the patients here, you can see here that she had both head tremor as well as the hand tremor, particularly with the kinetic. So this one is consistent with essential tremor because it's combined head and upper limb tremor. So this is the table show how to differentiate between head tremor and in ET and neuropathic tremor. Cervical dystonia with tremor, sorry. So in essential tremor, tremor can be decreased when lying down, and you cannot see now point like we just learned from yesterday from the botulinum toxin workshop, and no direction specific. While cervical dystonia with head tremor, the tremor can be worsened when moving against the directions of dystonia and can have now point with the positions that have less tremor and sensory trick. This video, I show you the dystonic tremor with cervical dystonia with dystonic head tremor. You can see here that she has irregular head tremor with the neutral position here. And when I asked her to turn the head to the right, here, I think the tremor decreased in terms of the amplitude. And when I asked her to move back into the neutral position, the head tremor comes again. And when I asked her to turn the head to the left, the tremor is lessened. So this is an out point. And when we ask her to lie down, you can see that the head still like this. So it means that the head tremor still occur when she lies down as well as when she sits. So this is the example of cervical dystonia with dystonic tremor. How about the task-specific tremor? So this gentleman, he has tremor while riding. But when you look at his hand, so we have learned from the workshop yesterday as well. I think it's sometimes difficult to say that the patient had dystonia, right? So no abnormal posture and no overflow, and no when we ask him to write on the contralateral hand, it's rarely see the dystonia with the mirror movement. So it could be in the category of primarily writing tremor, which is a controversy issue as well. This is in the category of dystonic tremor, or this is part of essential tremor. While the patients here, you can see here when he writes, he has tremor as well. But when he writes for long times, he has an abnormal posture, especially the extension of the wrist, and has an overflow to the proximal part. So this is in the category of right sacrum with tremor. So this is the algorithm for treatment of dystonic tremor, and the outcome is highly variable depending on the distribution of dystonic tremor. And we can prescribe medications such as anticholinergic or benzodiazepine for appendicular or generalized tremor, and botulinum toxin injection for axial or right sacrum. Moving to case 4, so this is 70 years old male who presented with 4-year history of isolated head tremor and 3-month history of bilateral hands at rest with a position-specific tremor while using the phone. You can see here that he has a tremor at rest. At first, this is a rotations of the wrist, and then he has a flexion extension of the finger, but more prominently on the left side. And when I asked him to mimic the position that he holds the cell phone, the smartphone, he has a pause of tremor, and then the tremor comes back again, which is consistent with re-emerging tremor only on the left side, but not on the right. And because of re-emerging tremor, so I suspect of Parkinson tremor, right? So I asked the patients to do the open and closed hand to test for the battery kinesia and also for the tapping. as well as alternating movement of the hand, and also ask him to walk. And you can see that he has decreased arm swing, maybe both sides, but has tremor at rest on the left side. So what is the most likely diagnosis? I think this is a little bit controversial, right? Because he has head tremor at the very first. So do you think this is ET plus, dystonic tremor, or Parkinsonian tremor? So I mean, in my opinion, because he has rest tremor and also has re-emerging one with questionable or subtle sign of Parkinsonism, I might think about Parkinson tremor. But let me show you how to differentiate between about rest tremor in dystonic tremor versus PD. You can see here that dystonic tremor can be occur at rest, as well as PD. But PD tremor, the rest tremor can be suppressed at the onset of the movement. It means the tremor is at rest like this, but when you ask the patients to move the hand, so the tremor stop. And it can be re-emerging again in Parkinson's disease, which is very specific for PD. You can also look at the position of the thumb. The PD is usually pure lolling like this, and the thumb is going to be fractions. While in dystonic tremor, the patient has an extension of the thumb, and the tremors could be fraction extension like this. And you have to look at the bradykinesia and non-motor symptoms that can be present in Parkinson's disease. This is an example of pure rolling tremor. I think everyone agree that you usually see this kind of tremor in the clinic at rest. So this is Parkinson's disease tremor. While this lady, she has extensions of the thumb, and she also has a rest tremor on the left side, as well as on the right. And she also had abnormal posture of the head, and also has some occasional head tremor. And she doesn't have position-specific tremor. And we also asked her to do the tapping, and it seems that she doesn't have bradykinesia at all. So this is consistent with dystonic tremor because of the rest, my postural, and the head tremor, and the thumb position is different. This is a PET scan. PET scan can be done in Thailand to confirm whether the patients have Parkinson's disease or dystonic tremor. This is a F-DOPA PET scan from the patient's case 4, that guy who have the position specific tremor while using a phone. And you can see the arrow size, right? So there is a decreased uptake at bilateral postural putamen more on the right than on the left, which is spare caudate nucleus. So this is suggestive of PD tremor rather than dystonic tremor. So this is an example of re-emerging tremor, which is specific for Parkinson's disease. And you can see that this gentleman has tremor at rest. And when we ask him to hold the hands up, the tremor comes back again. So this is re-emerging tremor. While this lady, the patient has rest tremor at rest unilaterally. But once she holds the hands up, the tremor occur right away. So this is called pure postural tremor that can be occur about 15% of PD tremor, and the frequency is a little bit higher. It's about 7 to 12 hertz, which is different from re-emerging tremor, which the frequency is the same as rest tremor. And kinetic tremors can be seen in Parkinson tremor as well, that may look like ET or enhanced physiologic tremor. Let me move back to just the jaw. I think most of you have seen a lot of patients with jaw tremor, and see who has tremor, A, B, or C. Maybe I'm gonna ask the audience from the floor, who think A has PD tremor, B, C. No one answer? Okay, so in A, you can see that the patient has jaw, like side to side jaw tremor in PD, right? While the patients here in B, you can see that he doesn't have tremor at rest. But when he opens the mouth, he has a tremor. So this is an action jaw tremor in essential tremor. And this lady has a vertical axis tremor like this. So this is a rabbit syndrome or drug-induced tremor. Another sign that can point to PD tremor is the tongue. Sometimes you can ask the patient to open the mouth without stick out the tongue. At rest, you can see tremor like this here and the tongue, but once he stick out the tongue, the tremor stop. So this is rest tremor of the tongue, which is suggestive of PD tremor. And tremor in PD can occur at the leg. You can see here that it can be the thigh flexion extension on one side, or here flexion extensions of the ankle, and the abduct and adduct, which is not common in Parkinson's disease. Let me move to case 5. So this is a 50 years old female who presented with 1 year history of unsteadiness while waiting in the long line and decreased while walking. And you can see here that we even cannot see tremor, but we can touch it, right? We can try to touch her leg and maybe use the stethoscope to listen to tremor bursts. And you might hear the tremor bursts, maybe we can call helicopter size. And actually, when you see her skirt, it's a little bit moving. So actually, this means that this is not psychogenic, right? So this is a real tremor. And I think everyone agree that the most likely diagnosis could be orthostatic tremor. But we can do the physiological study to confirm that and exclude other syndrome that look like orthostatic tremor. We have done put the surface EMG at TA and gastrocnemius both sides while standing. And you can see here, so this is 1 second. And you can see rhythmic EMG bursts at the peak frequencies around 16 Hertz, which has a high coherence between TA both sides. So the electrophysiological or tremor study can confirm the diagnosis of orthostatic tremor. And this is the last case. So this is the case of young male who presented with acute onset of head shaking and abnormal movement on the right hand 1 month after bleeding pontine carbonoma. From the video, you can see here the head titubation and also irregular tremor at rest. And once we ask him to hold the hands up like this and do the finger to nose, he has very irregular and higher amplitude during the kinetic movement on the right side with dysmetria. And we can observe at his eye, he has left eye ptosis, right? And once we ask him to open the mouth, I think everyone's maybe try to see inside the mouth at the palate. You can see palatal tremor as well. So what is this diagnosis? Holmes tremors, right? Because this is a combined tremor who has a tremor with the cerebellar side as well as the brainstem side, and the tremor occur at rest and increase with action. So this is a table that can explain the characteristic of home tremor, which look like myoarrhythmia. Home tremors and myoarrhythmia is really slow frequency tremor, which can be irregular and jerky. But in home tremor, it's more sinusoidal like this, and the amplitude increase with action. While myoarrhythmia like this is a semi-rhythmic EMG contraction with the same amplitude between rest and action. But because you can see here that the tremor occur only in one side, so you have to almost always look at the structural brain lesions, particularly in the Gilland-Malalet triangle, which is consistent of contralateral lead nucleus, contralateral inferior olive, and ipsilateral dentate nucleus. So this is the MRI of these patients, and this is a pontine hemorrhage at the onset of the symptom. But when the tremor starts, you can see the breathing subside, but there is an increased intensity and hypertrophy of the contralateral inferior olive, which can explain the home tremor and palatal tremor. And this is an algorithm that you can go and see in terms of the treatment. But I have to let you know that the treatment is not very good responsive to the medications. Take home message. Evaluation of tremor should almost always start with exclusion of tremor mimics like myoclonus. The second step is to determine tremor syndrome based on the characteristic of tremor in combination of additional signs to decide whether this is a combined or isolated tremor. Tremor syndrome can be changed with time if additional signs develop. And I have to emphasize that essential tremor is a syndrome, so it can have multiple etiologies. Investigation and treatment is based on the etiology and tremor type, and the treatment is based on the symptomatic. And I think the next two speakers are gonna talk about medications and surgical treatment of essential tremor, which can emphasize this topic in later. Thank you very much and for your attention.